Good afternoon, everyone. On behalf of Pediatric Respiratory Society Delhi, I welcome all in the very useful clinical meeting. And at the outset, I would like to introduce new office bearers of Pediatric Respiratory Society Delhi. So now the president is Dr. Anil Sachdev. He is consultant pediatric pulmonologist, Sir Gangaram Hospital, Delhi, and Vice President is Dr. Jasmeet Kaur Padwa, and she is consultant pediatric pulmonologist at Action Balaji Hospital, Paschim Bihar, Delhi, and General Secretary is myself, Dr. D.K. Jha, a keen learner of pediatric pulmonology, and executive board members are Dr. Kanaram Jat, Dr. Neeraj Gupta. Dr. Kanaram Jat is from AIMS New Delhi. Dr. Neeraj Gupta is from Sir Gangaram Hospital, consultant pediatric pulmonologist. Dr. Dhulika Dhingra is consultant pediatric pulmonologist. And Chacha Nehru Bal Chikitsalaya, Gita Colony, Delhi. And Dr. Hema Mittal is consultant pediatric pulmonologist at Ram Manohar Lohia Hospital, Delhi. And Dr. Mandeep Walia, she is consultant pediatric pulmonologist at Max Hospital, Saket, Delhi. So I welcome all in the society, and let us start the clinical meeting, and I will hand over to Dr. Anil Sachdev from Gangaram Hospital. He is the host of today's clinical meeting. Sir, please.
Yeah, good afternoon, everyone, and welcome to the bi-monthly meeting of Pulmonology Chapter, Delhi. So I welcome and thankful to all my executive and the office bearers for their hard work to organize this meeting. And I have specially thanked Dr. Vrinder Singh, who is our speaker today. Dr. Vrinder Singh is professor from working in Kalavati Saran Hospital, and he is a renowned pulmonologist. And I believe he is the right person to tell us what is the impact of changes in GINA guidelines on our daily practice or in daily working. So over to Dr. Vrinder Singh.
Thank you so much, Dr. Anil, and congratulations to you and your team for taking over PRS. I am sure PRS will make great progress with your team. I have to speak on the GINA updates today. How do they impact us? So, if we look at the GINA 2022, they are largely kind of developing on what came up in 2019. So while I've taken the slides from GINA as they give the update slides, the commentary is going to be mine, and I have taken liberty to add the slides from 2019 and 20 also into this where relevant.
Yes, now visible. The slide is not visible, but
okay, I'll try again.
Yes,
is
yes.
It visible now?
It has come now, yeah.
Okay. So I'm going to speak on the updates and give my comment on that as we understand what is useful or not useful or for us. One of the things which is always kind of affecting us is that if there are frequent change of guidelines, then one wonders as to how far we need to change and how quickly we need to change, and whether all those changes are relevant to us. The context of global guidelines, now a new word is used, and that word is development. And what do we mean by that? Once a guideline is developed for a global use, it can be used locally in any country based on three major ways. One could be a complete adoption of the guideline, that whatever comes your way, you adopt it. Second could be an adaptation, where you adapt it to your whatever fits you pick that. And third is the development. Development could be that, okay, you de novo create your own evidence and you create your own guidelines with or without evidence in some certain cases. So the combination of this is the word has been used as the development. And I think we must keep this in mind whenever GINA or any other global guidelines come up. And I'll elaborate this a little more when we go by. We know it was established by WHO, later on largely taken over by certain sponsors and had stayed with them. Again, some control of NHLBI is coming, but NHLBI is no. Then earlier, the expert guidelines, the expert reviews were named as GINA, and now NHLBI is not directly involved with GINA. With that background, in 2022, one of the things which they brought out is, before I go into details, I must mention that GINA guidelines are not only for pediatrics, they are for asthma of any age. So they also sometimes are very generic and not necessarily related to pediatric asthma, and that is something we must keep in mind. They talk a lot of difficulty in diagnosis when the patient is already on treatment, and this often happens in our scenario also, that patient is already on ICS or on treatment, and then when you do the test, if you are able to do a objective test, so we still talk a lot about clinical diagnosis, which means there can be a over as well as under diagnosis. But this becomes difficult if the patient has been on treatment, because the variability in lung function or system symptoms or hyper responsiveness will decrease with use of steroids. So they have updated this approach, and I think this particular table is quite useful for us to understand that they say that if there is a variable symptom and variable airflow limitation which is responding to dilator or constricting, then the asthma is confirmed. So that's one scenario, not a scenario for which we are worried, because there you have an established diagnosis. But often you would have a patient on treatment, and then therefore you may not get variability in symptoms. You may get symptoms, that is why the patient is coming to you, but you may not get any variable airflow limitation. In which case, repeat testing after withholding bronchodilator or when the patient is symptomatic is recommended, and this is what the 18 used to say. You may consider even stepping down of controller therapy if the FEV1 is more than 70% if your diagnosis is questionable. The third scenario could be that you have few respiratory symptoms and normal lung function and no variable airflow limitation. Here, one has to withhold bronchodilators and repeat the bronchodilator responsiveness to make sure. Otherwise, one has to consider alternative diagnosis. Stepping down of controller treatment can also help us, that if the symptoms re-emerge and lung function fail, then asthma is likely. But if there's no change in symptoms, then one has to consider further tapering or ceasing the controller and then see what happens to these symptoms, whether they come back, and then you make a diagnosis of asthma. If they don't come back, you may consider that either it was a wrong diagnosis or there is a natural control. The last situation, less common, but about which we are more worried, is persistent shortness and persistent airflow limitation despite on therapy. They say in this situation, it may be worthwhile, because you can't step it down, to consider stepping up control therapy, reassess the symptoms and lung function, and then decide what is to be done. If there is no response, then the previous treatment. And this is largely where they have an asthma COPD overlap. So in our situations, when you have a persistent shortness with airflow limitation, we think more in terms of severe asthma. Or sometimes one differential could be a bronchiolitis obliterans like small airway disease. So in the context of country like ours, where I'm sure our PM is not going to like the word of low and middle income, we are an aspirational country. So I would rather say, this is Gina's word, maybe we could call ourselves resource constrained countries like ours, where if the spirometry based testing is not available, they still say that you can use peak expiratory flow rate and more than 20% increase after 2 puffs of salbutamol 50 minutes after that make asthma likely. This is somewhat controversial. Yes, it can be used in place of spirometry as a screening test, but remember, peak expiratory flow rate is quite dependent on the way the patient does it. And there can be a lot of variation between the three readings you get, and I'm not talking of physiological variation. Even the process itself is not really repeatable, and that's something which we have to keep in mind. That the changes which we see in PF or may not see, we may wrongly diagnose. But this is something which is recommended in the resource constraint constitutions like us. They say that we should improve the access to affordable diagnostic equipment and skill training. And I think that's another area where ATM and our chapters have been working, and PRS can think of late. We haven't done many ATMs in Delhi, so we really need to see. In the recent examinations of DNB or MD, I realized that our youngsters and some of the faculty were also quite jaded on asthma. So we really need to go back and see whether our need for ATM training is how pertinent it is in today and what we can do. Coming back to GINA, 2019 GINA was something which brought the most fundamental change in asthma management. And it started recommending always a combination LABA with ICS as a predominant therapy, and saying that short-acting bronchodilator alone now should not be used. What brought this change in 2009? The understanding that the mild asthma is not really mild because there are risk of serious adverse events. There can be up to 15% of these children having near fatal asthma, nearly 30% of adults having an acute asthma, despite otherwise having a mild symptoms in between, which are less than a weekly, that means about a monthly symptoms which you have in prior 3 months. And since the exacerbation triggers are very variable, these mild asthma, this people have used this as a something which is a dynamic process. You may be a mild asthmatic today, but the disease may not remain mild after a while. And mild asthma does not mean you cannot have severe exacerbation. So these were the difficulties they had, and it also says that when we say episodic treatment with SAVA, then often for exacerbation you use OCS, and up to 4 to 5 OCS courses can increase the risk of osteoporosis, diabetes, cataract. I am not sure I agree with this reference, because we do use OCS courses and have been using them for a long time. We haven't seen a significant increase in diabetes or cataract, at least in pediatric age group. I don't know whether even our colleagues who deal with the adults have seen more of it, but this is what is recommended based on some data. So the inhaled SAVA has been the first line therapy, but to this they said that this causes confusion because they think the reliever gives them control over asthma, and therefore ICS may not be taken. So for these reasons, and for reasons of SAVA being associated with adverse effects, down regulation, with an increase in adverse clinical outcome, SAVA should not be used is something they are saying. Now, I will first take you through what the guidelines are, then give my comment on it. So since 2007, GINA has been actively seeking interventions for mild asthma, how the related exacerbations can be decreased, how to avoid the patient reliance on SAVA. He emphasized the poor adherence is a modifiable risk factor, and therefore, when there is a reliever is SAVA poor, there may be a poor adherence with the maintenance controller, thus increasing the risk of SAVA, the patient who are on SAVA only treatment. And they have therefore done certain studies. So the first study which they did was a Sigma study 1 and 2, and novels restart, and in which they found that when you compare to as needed SAVA versus low dose ICS formoterol in mild asthma, what we used to call as step 1 earlier, it reduced the severe exacerbation by about 2/3. When you compare this with maintenance low dose ICS, which is step 2, the risk of exacerbation was very similar in 2 studies and lower in another 2 studies. And there were small differences which actually favored maintenance ICS, like the increased mean differences in FEV1 or FENO, though they were clinically not very important difference it was considered. All these, when meta-analyzed, they show that with SAVA alone, you have 55%, compared with SAVA alone, ICS formoterol in mild asthma decreases the severe exacerbation about 55%. But it is very similar when it is related to daily ICS. And this is something which is very important for our context. ED visits are reduced with ICS combination with LAVA. So now they recommend that treatment option should be in two tracks. Unlike in 19 and 20, where they were almost categorical that we should have only one track, that everybody should be on low dose ICS formoterol. Now they are talking there is an alternative, need for an alternative, which is the erstwhile what we were doing. Take ICS whenever SAVA taken is something which changed. Earlier at step 1, we used to say only SAVA. These were patients who had monthly or months or less less frequent symptoms. And when you had weekly symptoms with or once a month nocturnal, you were on low dose maintenance ICS as step 2. This was the erstwhile learning we had, and gradually this to step 3, 4. To which now what the GINA is recommending for children below 12, above 12 years of age. So that's very important. It's for adults and adolescents, not for all age group. They say that instead of SAVA, both they merge step 1 and 2. So the reasoning they give is that this was very arbitrary, that whether you had once in a month or twice in a month, these were arbitrary divisions and they do not really relate with the risk of exacerbation. This is the reasoning they are giving. So they recommend that we should use as needed low dose ICS format. So this is something we have to debate, and we will discuss as we go by. So the change in therapy, the assess, adjust and review cycle always remains, where you look at comorbidities, you look at the inhaler technique and patient preferences. So what they are recommending is as needed versus an alternative which is considered poorer. So where either developing countries where ICS LAVA combination is very expensive or not available, like Africa, not our country. They say use alternative, use the old regimen which was there. And then alternative is the LTRA, about which it has gone further into gray zone, not so recommended. The other changes they are recommending is low acting LAMA should be used later stage, but not as a monotherapy, always with ICS. And adding LAMA to ICS LAVA, there is only a small increase in lung function, but no clinically important benefit if the symptom is dyspnea. So therefore they say don't prescribe LAMA for dyspnea. I think we largely don't use LAMA. It has been mainly used by asthma COPD combination in adult. We have used this more in the context of small airway disease, which is not same as asthma. So the benefits are very, very, very mild. They are also talking of anti-IL-4 and as a therapy for children between 6 to 11 years. So 6 to 11 years of age, they still continue with the same step 1, 2, 3, 4, 5 as was there earlier, except with one difference. The step 1 should have low dose ICS taken whenever SAVA is taken. So all our life, Dr. Anil Sachdev would remember we had been fighting with Cipla to stop Aerocort, which was their combination of SAVA with beclomethasone, one of their very high selling product even today. Every RMP would use, because when we started working with rational therapy of asthma, this product was something which was not very scientific and was given at all severities and with variable doses, and something we had kind of discarded from our armamentarium now again peeps in as for step 1. I'm not sure whether it is right, because at step 1 we are talking of continuous therapy. We are talking of steroid therapy even episodically in the hand of the patient. Patient decides how many puffs, and we had these concerns about SAVA overuse and wrong reporting or poor assessment of therapy, of severity, which impacts the therapy with the with an SOS SAVA, where you were using more often oral than inhaled, or if inhaled, it was nebulized, because it did not make sense to educate families on inhaled therapy when they would use it once in 2 months or once in 3 months. They would not even remember and use it for 4 or 5 days. So therefore, we were never impressing upon these families to remember ICS, MDI spacers. So if we are going to load those ICS with SAVA in this situation for its benefit, uh, we are one giving an ICS combination in the hand of family for an SS use. We also therefore would have to educate every child with asthma, irrespective of severity, on inhalation therapy. How that skill would be maintained is something which we really need to review. And this argument which I am giving holds as much true for children who are above 12 years of age, because there also it is the same story. If you are uh, in step one, it doesn't make sense to take continuous ICS lava or ICS lava repeatedly as your first choice. For some putative benefit, which some studies have shown equal and some studies do not show them to be. When it comes to the later steps, there are no changes except that they at step 2 we were earlier using only ICS, and now they recommend ICS lava in most situations. When it comes to below 5 years and younger, the old regimen, which is daily low dose versus, sorry, the slides are jumping. The daily low dose, and at step 1, uh, using only SAVA. Here, what they've added is one of the earlier previous studies and others where they had considered intermittent short course ICS at onset of viral illness, that you give them high dose short course of ICS. There has been a lot of comments on that, and the experts feel that with the high dose, which is about 400 to 800 microgram of budesonide given within viral illness for a short course, it was almost equivalent to a oral corticosteroid for a 5 years in younger child, and therefore that's something which has been questioned in the past, but now peeps in this GINA guideline that you consider. They're not recommending, they're saying it is limited indication, there's less evidence, but you should consider. So this is what the GINA is now recommending in 2022 as a change, more emphatically for children above 12 years, no change below 5 years, and some change between 6 to 11 years in terms of using SAVA witnesses. There is some review on where to start initial therapy. Practically no change, but they have reviewed this. This came in the 2020 guidelines, which were kind of shadowed by COVID, so we did not have a lot of reviews on this. By the time they came in May, we were already into the COVID lockdowns and others, and these were not discussed at that point of time. But these symptomatology, which were earlier lost, was earlier there. We used to call it mild, intermittent, mild, persistent, moderate, persistent based on symptoms. The terminology has gone, but at what stage you start has come back. And now what they also recommend is that then we had replaced this mild, intermittent, etc. with the terminology called that at which step of therapy you are, step 1, 2, 3, 4, and you call that. But now what they're recommending is you only say asthma on such and such therapy, because it's a constant cycle of adjustment of and verifying what the impact is. So you assess, adjust, and verify that circle which we have of regulation is there. Therefore, what they say is do not use the word step, only say what treatment you were getting. So it's kind of synonyms. The steps were always in the context of it, but that's what is now mentioned. The initial controller, once you are starting, you have to first assess for confirmation of diagnosis, symptom control, modifiable risk factors like exposure to triggers, look at comorbidities like obesity, rhinitis, look at NLS technique, patient preferences, and then decide at what step what therapy you are giving. This is the same which we have been talking in the past. So this is broadly what the update is on the regular therapy of asthma. Just to bring the concept, what it time and again says low, medium, high doses of ICS. There has been no change. It is same. About 200 to 400 is low for children up to 12 years, and for 6 to 11 years, it is about 100 to 200 microgram per day, and 50 to 100 when you go below 5 years of age. Unfortunately, we often do not get the prescription, the drug of with 50 microgram strength of fluticasone available. Earlier, Cipla was making it. They were to relaunch it, but it's hard to get. So you land up giving 100 microgram even to young children if in the situation where you start. Perhaps in that case, if the patient is controlled, into OD doses 100 microgram rather than 50 BD, maybe one way we can work around. In a relatively controlled child, that is possible. There has been again a kind of a FDA black box warning regarding Montelukast that it includes it increases the suicidality, suicide tendency in adults and adolescents, and nightmares and behavioral problems in children. So this is something they said that these neuropsychiatric symptoms should be considered in the risk-benefit profile when the patients are considered. So this is something which has come back. There is also something which does not happen, but Delhi IAP has been very particular about a lot of programs which should be taken to school. So PRS can think how they can piggyback with that programs going back to school, which Dr. Taneja had brought, and think of school-based programs on asthmas, because they are known to decrease the emergency department visits, hospitalization, days of reduced activity, because children, when they have some cough and are known asthmatic families, may not send because there is no school-based program. Maybe some of you would recall that we had death in a very high-profile school of Delhi and of an asthma child, because they kept on, calling the family, take this child for treatment elsewhere, and precious time was lost because there was no asthma management school-based program, while most schools have a health professional, a school health nurse available. So management of acute crisis, where we allow self-management, why this can additional responsibility not be shared by the schools when the parents are not available, because they are known to decrease the emergency department visits and hospitalization. And maybe in the incident case I was talking of could have prevented the death of a child. So this is an area where we as a body can work on. There are more drugs which are now recommended for children between 6 to 11, like mepolizumab has come with severe eosinophilic asthma. There is also a lot of work and separate work coming on severity and talking of how to manage. There are short guidelines on difficult to treat and severe asthma. This is now coming up as to what additional investigations one has to do, like for adrenal insufficiency, because these are on very high doses, or those who have high eosinophil, to give them deworming therapy, which we were doing in the tropics earlier, but now has come back in the GINA, and they say, do you give this before you consider biological therapy? And to investigate for EGPA when you are having hypereosinophilia more than 1500. They have recommended different add-on therapies, particularly anti-IL-4 and anti-TSLP, which is thymic stromal lipoprotein, lymphoprotein, tezepelumab for children more than 12 years of age. They recommend the same difficult to treat protocol, which we talked of earlier, where you look for, confirm the diagnosis, look for factors, asthma education, and then see whether it changes or not, and come to a diagnosis of uncontrolled to a severe asthma. And then depending on whether you have type 2 eosinophil counts, after a trial of deworming, talking of addition of LAMA, LAMA's low dose azithromycin, anti-IL-4, anti-TSLP, depending on the eosinophil counts, This is what, and finally, the other biologicals like omalizumab or mepolizumab in children. So this is what we have newly added for children below 12 years, and above 12 years you also have NTTA, TSLP, and NTIL4. So these are something which has come up in a separate booklet by Gina. This is a small but very important area where now we have more written guidelines available to us, and there is no great deal of difference in what was recommended in the past, except for the new drugs which have come, for which we do not have any in-house experience to recommend anything alternatively vis-a-vis what the comments I made on other recommendations of GINA. They are also now talking of changes or clarifications in GINA, that there should be written action plans and not just verbal instruction, which is could be written, printed, digital, pictorial. And acute asthma, now there is more and more work going on whether instead of salbutamol, formoterol should be used, and one could use the same inhaler with ICS for crisis management. When we what came up as earlier as a smart therapy, and now a single inhaler being used for everything. Something which gets a reflection, and whether in acute asthma also we should be using the combination of formoterol with ICS. That's another recommendation which has come up. Air filters can reduce fine particle exposure, but have not been shown to have consistent effect on asthma outcomes. So this is something which is important when you get your questions on home air purifiers and air filters. And e-cigarettes are as bad as other cigarettes. There is also a large set of update on COVID-19 and asthma. I'm not going to speak about it because we have a panel discussion in a short time after that. And this is my last slide, which is on topics which they plan to address in the subsequent future GINA reports, largely on the allergen immunotherapy and diagnosis, assessment, and management of asthma in children below 5 years. And as is apparent from the tone of 2022 document, which is not as strident as it was in 2019. Even GINA is now talking of further discussion about definition of mild asthma, assessment, or what tools to use. So they're kind of iffy. In their discussion, though in the guidelines, they seem to be very prescriptive about users of same ICS with the LAVA for mild symptoms, episodic, and for step 2 as daily therapy instead of ICS alone. Though they also say that if you are already having someone who is controlled on step 2 therapy with ICS, there is no need to put them on LAVA ICS, and there the earlier strategy could be continued. So the recommendations are still kind of both ways. And from my personal viewpoint, I think there is no robust data which has come our way, which very clearly suggests that the change is imminent. What is recommended, we must also remember as a body of PRS or IAP NRC, that any change in guidelines, though looks good that it is updated and we are updated, often is a repackaged old bottle. But the cost of retraining everyone is huge, and sometimes very repeated changes discourages families as well as your providers. Every year they bring a new guideline, and I don't know how much change it brings, and people lose confidence in the guideline. So we really as a body have to think with every update of GINA, is the recommendation significant enough and strong enough on the available grounds for us to change our practice? I don't think it is the case for us to change our practice for step 1 therapy with a combination of ICS with SAVA, because the studies which they show, for which they compare, they clearly show that these are the patients who actually would not have qualified at step 1. They were on SAVAs, they were misreporting their symptoms, the reporting was not happening. Only those had the severe exacerbation. Those are the ones who died. Yes, there is a small proportion, less than 10%. We know even when you look at mortality of status asthmaticus or acute severe asthma, nearly 10% of them have this is their first attack. They never had a past history of asthma. So even if you give someone episodic use of ICS LABA, those 10% would stay. So I don't think, if you look at the overall picture, the argument of changing this therapy in children where even low to moderate dose, high dose, moderate dose ICS can have an impact on pituitary axis, can have an impact on their growth. We have evidence strong enough to change our practice. This is my personal view. I'm open to discussion. Thank you so much.
Thank you very much, Dr. Virender Singh, for highlighting the differences and between the previous GINA guidelines and the recent ones. And the highlight of your talk was your personal comments and how you have dissected everything. It was very impressive. So, Dr. Jha, are there any questions?
There is no question.
Because everybody was spellbound, huh?
Everybody was clear after the speech of Dr. Varinder Singh, sir. So there is no question.
Right.
We are a
Thank you
small-
very much.
Thank you. Thank you very much.
Thank you very much, Dr. Vrinder. So next is our panel discussion, and Dr. Jha is the moderator, and he will introduce the panelist and start the panel discussion. Over to you, Dr. Jha.
Thank you very much, sir. Just my slide is opening. So the panel discussion topic is asthma and COVID-19, friends or foes, दोस्त हैं या दुश्मन. So our panelists are Dr. Jasmeet Kaur Badwa, and she is senior consultant pediatrician at Action Balaji Hospital, Paschim Bihar, Delhi. Other panelist is Dr. Neeraj Gupta. He is consultant pediatrician at Sir Gangaram Hospital, Delhi. Third panelist is Dr. Neetu Talwar, and she is pediatrician at Fortis Memorial Research Institute, Gurgaon. So just let me open the slide. 1 minute, please. Again, I am stopping, then sharing. My slide is visible or not?
Yes, it is visible. आप शो पे डाल दो.
फुल स्क्रीन कर दीजिए.
Put it on show.
I'm not able to see the slide, so.
सर ऊपर से डाल दीजिए, जहाँ ऊपर लिखा हुआ है ना होम इंसर्ट डिजाइन, वहाँ पे स्लाइड शो है, वहां से डाल दीजिए सर. यहाँ स्लाइड शो से सर राइट में, और थोड़ा राइट में सर, एनिमेशन के राइट में, यहाँ से सर.
Yes.
इसको सर फ्रॉम बिगनिंग कर दीजिए, लेफ्ट साइड
From
के जस्ट
left side में.
लेफ्ट साइड में फाइल के जस्ट नीचे सर,
extreme left.
From beginning.
Yes.
इसको बिगनिंग कर दीजिए सर.
Now it is
Yes.
visible.
Okay, now it is okay.
Okay. Thank you very much. So the topic is childhood asthma versus COVID-19. So childhood asthma is the most common chronic respiratory disorders in children. On the other hand, COVID-19 has been the most severe pandemic in recent 100 years. So it is a general presumption that any disease which is affecting the lungs primarily may cause the seriousness of COVID infections. And COVID infections, initially it was presumed that the mortality is 2%, but now it has been concluded that mortality all over the world is approximately 7%. So it is very high. And there is very few study regarding asthmatic children getting infected with COVID and how serious it is. Either the asthmatic children is with controlled asthma, uncontrolled asthma. So there are very few studies in comparison to the studies of comorbidities in adults like diabetes or cancers, other things. So there is one European guideline which just presumes on the common sense that COVID-19 is a systemic disease, but most severely it affects lungs. So if the lung is already compromised with asthma, so the COVID-19 will be serious, but it is based on common sense. There is no evidence till date. So we will know by our panelist what is this. So our first question will go to Dr. Jasmeet. Asthma, is it a risk factor for SARS-CoV-2 infection or its severity? Dr. Jasmeet, please.
Yeah, thank you, Dr. Jha, for having me for this panel discussion. And because of this era of COVID pandemic, which we faced for past 2 years, and I think in the past 2 months, we all have faced the virus triggered acute asthma insult, which occurred in last 2 months in school going children. And I think all of the OPDs were full during this time. So I would like to highlight what is it exactly. Though the data on this is very scarce, as Dr. Jha said, but there is one systematic review which was done, and it was published in Pediatric Pulmonology Journal, in which they taken the data from 2020 March till 2021, and they have studied, or they've taken the data from Wuhan, China, Italy, and Europe, and they found that the incidence of COVID was very less than 2% in children as compared to adults, and 0.01% was the mortality. Now, among that, there was only 2 published studies which said that the asthma can be a potential risk factor, or those children who were having asthma or recurrent wheezing, they might be having a potential risk factor for having a SARS-CoV-2 infection. In fact, there was also one case control nested study in which hospitalized patients were admitted. The asthma hospitalized patient children were more than the non-asthmatic, and that too in the less than 10 years of the age group. But in that also they had seen the infection part was very much controlled. Means the asthma does not pose much of a risk factor for having a SARS-CoV-2 infection in children, unless and until the children are having severe asthma or they're uncontrolled asthmatic. If they're uncontrolled asthmatic or severe asthma, they might have this risk factor of SARS-CoV-2. Other than that, the data is very scarce, and there is not much of studies that it is a risk factor for SARS-CoV-2. On the other hand, it is also seen that those children of asthmatic children having a SARS-CoV-2 generally have a milder disease, like they have just lethargy, fever, myalgia. They may not succumb to any illness, may not have more morbidity, though it is less again in children, because there are some immunomodulatory effects which will be going on further. They have some they are type 2 inflammations, asthma, and COVID is type 1 inflammation. And along with that, if they're already on good control, then these are protective responses to the COVID infection, as compared to influenza virus and the other respiratory virus, which used to trigger the acute exacerbation in asthmatic children. But coronavirus has been seen that it do not trigger the acute exacerbation of asthma unless and until the child is severely asthmatic and uncontrolled and not on any other immunotherapy. So on and all, the nutshell is that all the studies have been done, and they're scarce in children. They are very less data in children, but they sense that only 2 studies were found to have a potential risk factor for child having asthma and persistent wheezing. Otherwise, they were not assumed to be having a risk factor. And that too, if they have infection, that is a milder course of infection. And this SARS-CoV-2 infection does not go for any acute exacerbation of asthma in children. As such, it is not prone to other than the other respiratory viruses.
Thank you, Dr. Jasmeet. So according to Dr. Jasmeet, asthma is not a predisposing factor for risk of COVID-19 or its severity. So I'll move to next question, and the next question is, what is the concept of angiotensin converting enzyme 2 receptor gene expression in the airways related to asthma and COVID-19? So this question goes to Dr. Neeraj. Dr. Neeraj, please.
Thank you, sir. And as we all understand for past 2 years, that SARS-CoV-2 virus usually affects through the ACE2 receptor. And these ACE2 receptors are predominantly present in the lungs. And then they are also found simultaneously in intestine and heart also. Now we also understand that wherever the ACE2 receptor concentration is less, like for an example in children and elderly, then at that time they are less predisposed towards this COVID-19 infection or the severity. So that is why children are probably more protected through COVID-19 because of the lesser number of receptors in their body. On the other hand, elderly, though the receptors are low, but the comorbidities are high, and that is why they were more vulnerable. Otherwise, the receptors by themselves are low. Now, when we talk in terms of asthma, so in asthma, now we are talking in asthma in phenotypes and endotypes. So there are several endotypes which are now available, and we know about that, like Th2 high endotype, then Th1 high endotype, and then there are mixed and then polygranulocytic, in which the Th2 high endotype, which is actually associated with certain interleukins like interleukin 4 and interleukin 13, they have to be found to be having lesser ACE2 receptors. In a way, we can understand that a patient or a child who is having a Th2 high type of asthma or allergic type of asthma, then at that time the ACE2 receptor concentrations are less and they are less predisposed towards COVID. On the other hand, if a patient who is having a non-allergic asthma, that means a Th17 mediated asthma, interleukin 17 mediated asthma, or Th1 high or Th2 low basically. So they are like having more number of ACE2 receptors, and that is why they are more predisposed towards COVID-19. So we cannot simply say that all asthma are same. It will depend upon the endotype basically. And then simultaneously, we need to also understand that whenever there is Th2 high phenomena is going on, then eosinophils are also high. And increase in the eosinophil count is also protective. Even there are few studies which have seen that on the day of admission because of COVID-19, if there is eosinophilia, which is found to be having a better prognosis in those patients as compared to other patients who were having zero eosinophil count on the first day of admission. There the mortality was found to be more high. So what I want to say that if there is a high Th2 inflammation which is going on in the body, that is somehow protective for COVID-2 receptor, as basically COVID-2 infections.
So, according to Dr. Neeraj, because of the less amount of AS2 receptors in children, severity of asthma is less in children. So thank you, Dr. Neeraj. Just I want to add 1 or 2 points here. As you have said, Th1, Th2 types. In general, children have less expression of ACE2 receptors in the type 2 cells of the alveoli. So in general, in comparison to adult, they are suffering less. The severity is less. Now, if you compare between Th1 and Th2, then Th1 will be more sufferers. Second point on eosinophils, what happens whenever there is bacterial infections, automatically eosinophil count in blood is low. Even if the child is asthmatic, and if there is secondary bacterial infection, we will see eosinophil count will be low. So eosinophil count is low means there may be some secondary bacterial infection in that child, so there will be more severity and there is more chance of mortality. So there may be one factor for more severity of the disease in case where there is low eosinophil count. Thank you, Dr. Neeraj. I'll move to another question. Viruses are the most common exacerbating factor in childhood asthma. So how to differentiate between exacerbation of asthma due to coronavirus infection or coronavirus disease per se, that is COVID-19? So Dr. Neetu, please.
Yeah, so thank you, Dr. Jha. So, like we have all seen in the previous, the two panelists have discussed that per se, corona is not, according to the recent literature and the various studies which are going on, it is not considered as a confounding factor neither for having exacerbations nor for having severe outcomes like a poor outcome or mortality. Nevertheless, if in the midst of a pandemic, as we all know, viral infections are triggers for acute exacerbations. So if there is a pandemic going on, definitely we would consider that probably it is the coronavirus infection which has been the cause of the exacerbation. And as we also know, coronaviruses are the second most common cause of common colds in children. And SARS-CoV-2 is the newest addition to that group. So anyways, it is a very common known factor which is going to cause common cold in children. Now, how to differentiate between asthmatic exacerbation and COVID disease is simple. COVID disease will come with crepitations, and asthmatic exacerbation will come with rhonchi and wheezing. And of course, later on, we do the antigen test and RT-PCR and CT scan if required. So that is the most important differentiating feature.
Thank you, Dr. Neetu.
Yeah, and I would also like to add to what Dr. Neeraj had said about asthmatic children and SARS infection. So definitely a couple of points which I would like to add is in the phenotype, the type of asthma in children is mostly of the allergic type, in contrast to the non-allergic phenotype which happens in the adults. Now, the allergic phenotype itself will cause a reduced expression of ACE2 receptors in the airways and in the cellular lining of the airway lining of the children. At the same time, even the expression of TMPRSS2, which is considered to be an important factor which causes entry and worsening of the infection and entry point into the cells, that also would be lesser in children. Then the second point is that the steroids which we use in the treatment of asthma themselves will cause a lowered expression, cellular expression of both of these two important receptors, causing sort of a protection which has already been documented in the different studies. And as we all know, budesonide has also been talked about as causing a decreased expression of interleukin 6 and 8. Interleukin 6 itself is a surrogate marker for the severity of COVID. So all these things also help to understand how SARS-CoV-2, which was initially, we were all in the guidelines, GINA guidelines also told us that, asthma becomes a high risk, put the children on prolonged preventer treatment and all that. And then everything changed when the data started coming in from 2020, 2021. So now we know that aise kuch bhi nahi hai. Thank you.
Okay, thank you, Dr. Neetu. So, in case of moderate to severe COVID-19, it is easy to diagnose COVID-19 because it is a multi-system disease. Other systems are involved. Whereas in case of asthma, only lung is involved. So, but in cases of milder forms, it gets difficult to differentiate between whether it is pure asthma or COVID-19 or asthma with COVID-19. So, one point is if you give inhalational beta agonist and if there is predictive response, then you can say it is a asthma, not COVID-19, or maybe the asthmatic children suffer from COVID-19. Second is you raised the point about AC2 inhibitors in any children suffering from any kind of allergy, even if allergic rhinitis or atopic dermatitis, AC2 expression is less in the airways. So now I will move to the other questions, and next question is, should inhalational corticosteroids be continued once an asthmatic child on controlled medications with this medicine gets infected with COVID-19? So, Dr. Jasmeet, please.
Yeah. Yes, Dr. Jha, I think these questions got raised 2 years back also, like patients came to us, ma'am, should we give this inhaler therapy or not? Because it's a general view and prediction that long-term steroid causes immunosuppression, but this is not true. We all know that there is always a beneficial effect of inhaled corticosteroid on maintenance of asthma, and that too, the seen that controlled asthmatic children, those who are in good control of asthma, even if any other viral infection and CoV-2 infection occurred, it does not lead to any acute exacerbation. So inhaled corticosteroid should be continued. Now the GINA guidelines had also modified after the pandemic in 2021 also. They have emphasized totally that inhaled corticosteroid should be continued basically with proper valved spacer holding chamber, with or without mask, with or without bronchodilators, and it should not be discontinued, especially during the acute COVID pandemic, because otherwise, in the case of uncontrolled asthma and severe asthma, there's always a possibility of higher acute exacerbation of asthma. As to what Doctor, I would like to say something add with Dr. Neetu's question also, because there is a big difference between an acute exacerbation due to COVID or because of pure asthma. Because recently also we had seen many children got triggered with some respiratory virus and influenza, but generally getting the throat swab done, they were negative with the coronavirus. So it is true that respiratory virus go for acute exacerbation, but coronavirus itself has got some good immunomodulatory effect, means the same that it down regulates the ACE these ACE receptors, this thing. So that is why there's less possibility of having an acute exacerbation, even if the child is infected with coronavirus. Only problem comes when the child is uncontrolled. The child has left his inhaled corticosteroid, he is severe asthmatic, he has that type of what Dr. Neeraj has said, yes, that 5% or 2%, whatever they have, and they have these TH1 type of response. Those are the children, and the severe asthmatic, they come in that only, and the proportion who are not in the inhaler, they have the higher probability of having an acute exacerbation after being infected by SARS-CoV-2. So, coming to my question, the guidelines say yes, yes, and yes. Please do not stop inhaled corticosteroid in the era of pandemic, not even right now, because even by the other respiratory virus infection, the acute exacerbation, we have seen the children hospitalizing this time in the month of April immediately because they left the control therapy 2 years back and they get into problems, even if they are not infected with SARS-CoV-2. So the nutshell is that if you're taking your inhaled corticosteroid, please do continue with the proper valved chamber and not with the nebulizers, because we don't know if this infection is corona or any other influenza virus, and they need to continue this. This has got an immunomodulatory effect. Why? It has seen that in vitro studies have been done in mice. It has seen that budesonide, when given to a mice with CoV-2 infection, has got inhibitory effect on the replication of the RNA of the SARS-CoV-2 and also on the down-regulation of the ACE2 receptors. So both way, it has got a protective response. It do not lead to any other side effects. And that is why even it is shown that cyclosonide, though it is less used in children, but it has got, the studies are there, it is not yet published, but it says that it has got an inhibitory effect on the replication of the RNA of the SARS-CoV-2, and along with that, it has got the inhibition of the cytokinetic effect. So only few groups of the children can have acute exacerbation, which is very severe asthma, uncontrolled asthma, and that less than 5%, which has got non-eosinophilic type of asthma. So needs to be continued.
Thank you, Dr. Smith. So the ICS should be continued. At one hand, it controls the asthma, and on other hand, it gives the positive immunological response of body towards the COVID-19. So it is good to continue, and it is endorsed by British Society and GINA also. So
Yeah,
I
excuse me, Dr. Jha. Yeah, I would like to just add to what Jasmeet has said. So cyclosonide and mometasone, there are reports which definitely prove that they decrease the viral replication. Budesonide, on the other hand, as far as I have read, does not reduce the viral replication. It only down-regulates the interleukin 6 and 8. So that was just
many studies are going on.
Yeah.
Few studies. In fact, what we are talking are the published ones. There are so many data yet to come about it. Yeah, maybe it is.
I will come to next question regarding this also. So in case of acute severe exacerbation of asthma in children infected with SARS-CoV-2, oral or systemic steroids should be given or not? Dr. Neeraj, please.
So as has been discussed earlier regarding the inhaled steroid, so the same story holds true for the oral or the systemic steroids. So as per the merits of the exacerbation of asthma, if it is needed, then oral or systemic steroid should be administered irrespective of the status of the SARS-CoV-2 infection.
Thank you very much. So it is again endorsed by GINA guideline and PGS guideline, it should be given. Whereas there is no clear-cut guideline from American Academy of Pediatrics or American Thoracic Society regarding this, because there is not so much study. So I'll move to other question. As we prefer pressurized meter dose inhaler with holding chamber with or without mask as per the age of child, but we use nebulizers for the drug delivery in cases of acute severe exacerbation of asthma. So what is your opinion, Dr. Neetu, in acute exacerbation of asthma during periods of COVID-19? Dr.
Yeah,
Neetu.
thanks. Yeah, thanks, Dr. Jha. So at this point, I would also like to, repeat what we have been following in the past 2 years after the COVID pandemic has set in. And even before that, we have totally switched on to MDIs plus spacers, even in our emergencies, unless and until the child is very, very sick and really cannot take an inhalation and cannot coordinate. So that is something which we are anyways following in the emergencies. So definitely the PMDI with holding chamber, with or without the mask, is what we would prefer, unless and until it's completely impossible. Now, in what we also have done in these 2 learning years, what COVID has taught us is that we are having one room, one small area which is enclosed. I mean, it's a closed room in the emergency for those patients in whom nebulizer is the only option when they come in. So it is an isolated room, it is a negative pressure room, and whenever it is required, it is always advised to administer the nebulizer in that room, and then after the patient has been treated and shifted, then that room cannot be used unless and until it has been cleaned and thoroughly disinfected. Now, in those setups, where negative pressure rooms are not available, and even in our setup it is not very easy to get such rooms adjacent. So in that we could do some sort of a compromise and possibly have a separate room and then give the nebulizer and have the window open, something like that. I mean, but definitely not in the common area. And definitely the learning is that as far as possible we should be using inhalers with the chambers and make it a sort of a habit in emergency situations also.
Good, very good, Dr. Neetu. So, GINA guidelines also says that meter dose inhaler should be used. There is only one concern, that in cases of nebulizer, we can also give oxygen simultaneously, but there is sufficient evidence that if you give medications with meter dose inhaler and give oxygen with nasal cannula, it works equally or better than nebulizer. So, go with the MDI always, whether it is COVID or non-COVID. Thank you very much. So next question is,
I also discourage use of home nebulization, which is too much rampant.
Yeah.
This is very important not to tell them to buy the nebulizer.
So you should use MDI. Is it a fact that inhalable corticosteroid therapy leads to less cytokine productions and less SARS-CoV-2 proliferations, which are beneficial for patients, Dr. Jasmine?
Yeah, Dr. Jha, we just, basically these studies are still going on, and I just answered this question before, that in vitro studies have been done in the mice and all. In that, they have given budesonide, and it has been seen that the cytokine, in fact, in cyclosinide and all, they have seen that it inhibits the replication of SARS-CoV-2 infection and then inhibits the cytopathic effect. And in budesonide, it is basically down-regulating, it is sure, but even in the in vitro study, it has shown for less replication of this SARS-CoV-2 infection. And in this way, they have an immunomodulatory effect. It has also been seen in the sputum of the children with asthma, which are controlled already on ICS. They have shown that there is decreased eosinophilic production, and even these cytokines are less common in that. So there's a down regulation of these ACE inhibitors, and along with that is why there's a down regulation and inhibits the cytopathic effect, less replication. That means that they have the beneficial effects during this SARS-CoV-2 pandemic, and that is why if we see the guidelines of managing the CoV-2 infection, SARS-CoV-2, this time nothing was being said, not even with vitamin C and any other product, but they say if you're already on inhalers, please do continue it. They have beneficial effects, and sometimes even seen that in the prescription they've started the inhaled medication so as to protect the patient from these. So even the COPD patients and even in the asthmatic patient with not much of comorbidities, if they have already on inhaled corticosteroid therapy, it should be continued because they have a immunomodulatory effect. First, because of down regulating the receptors of the ACE2 inhibitors, and second, it has also been seen in vitro studies in the mice and the other that many of these inhalers have decreased the replications and decreased the cytopathic effect of the SARS-CoV-2.
Thank you, Dr. Jasmeet. So there is a double benefit, control of asthma as well as less severity of COVID-19. So next question is, this is very important and very relevant questions to Dr. Neeraj. So what is the current status of immunotherapy in the management of asthma in children? Dr. Neeraj, please.
Sir, I would like to answer this in two parts. First of all, immunotherapy in management of asthma, when we are not speaking about COVID-19 in routine management. Then at that particular time, definitely in allergic asthma, and it is having good role, especially if there is like a good allergen to treat with like a dust mite. And even Gina earlier editions have already suggested for sublingual immunotherapy for dust mite. And this time also Dr. Virender Singh just showed that they are further planning to explore further about allergen immunotherapy role. So definitely it is having good role in allergic asthma, especially to selected allergens like dust mite or pollens. Now, when we speak about COVID-19, then at that particular time, what allergen immunotherapy does is it changes the Th2 profile to Treg cells. And these Treg cells actually produces interleukin 10. And this interleukin 10 is having an anti-inflammatory property, which is reducing the cytokine storm of COVID-19. So even if a patient who is on allergen immunotherapy, and suppose if COVID-19 happens to that particular patient, immunotherapy should be continued. And this particular immunotherapy is definitely having, you can say, like the reduction in the severity of COVID-19 because the cytokine storm is reduced because of the interleukin 10 beneficial effects. So in both the conditions, immunotherapy is a promising tool, but right patient, right allergen, right time, that always remains the thing with immunotherapy.
Thank you, Dr. Neeraj. So this is very important thing to know that interleukin 10 is anti-inflammatory and this immunotherapy increases its level, so it is beneficial. So it should be continued even if the asthmatic child gets infected with COVID-19. Thank you very much, and thanks to all our learned panelists for clearing important doubts regarding asthma management in the era of COVID-19. Thank you very much, our learned panelists, and thanks delegates.
Dr. Jha, just 1 minute, one question to Dr. Anil sir, in case you permit. The question 5 which you had posed, that in case of acute severe exacerbation of asthma, should we give steroids or no if the patient has COVID? Magar COVID may be in the initial week, if the patient deteriorates, steroids are a drug of choice, and in acute asthma also the steroids are used. So why the controversy? So
there is no
Dr.
controversy. Neetu, there is no controversy.
Hanji, sir.
Well, I think the COVID severity in children is very, very low.
Yes.
And the asthma exacerbation may kill the child. The child
So
will not die of COVID.
So steroids to use करने ही है ना?
करने हैं, बिल्कुल, absolutely करने हैं. This is very clear from the panel discussion that the oral steroid or inhaled steroids, whatever indicated according to the clinical scenario, should be used. Yes, should be used.
हम तो करेंगे ही नहीं, तो ये question क्यों, sir?
Dr. Neetu, can I answer this?
Inhaled corticosteroid के बारे में है यार. When you have to use
oral or systemic.
Dr. Neetu, can I answer this?
You can use systemic if it is indicated, if the acute exacerbation, even by
yes,
SARS-CoV,
absolutely.
You have to use it. There is nothing, no doubt in it.
नहीं doubt नहीं था तो question क्यों मेरे को?
Dr. Neetu, can I answer this? Why this question?
Sure, Neeraj.
Yeah. So what my understanding is that when means like during the second wave of COVID, at that time the people were using a lot of steroids, and at that time asthmatic patients also came. Then there was certain confusion that during the time of severe asthma, if you are using steroids, systemic steroids, then at that time probably the immunity is getting weakened, and that might be probably increasing the severity of COVID-19. This was one question at that particular time, but later on people realized that it actually doesn't
Maybe not
weaken the
so. It
immunity,
helps.
which
Dr.
Dr.
Neeraj,
Justin already
Dr.
told.
Neeraj, if the patient is asthmatic, then you should not think about it at all. Huh? Her question is that the patient is asthmatic, having serious COVID infection during that time, it is justified to
Maybe,
use oral and oral or injectable
Agreed,
steroid.
man. Agreed. I'm just saying that why this question came. So I'm just
why this question?
Yeah, I'm just saying that why this question.
Maybe that was
Because it causes
Dr.
immunosuppression.
Neetu, the confusion was based on only common sense that steroid weakens the immunity
Yeah.
and then there
Yes.
will be more severity of COVID-19.
That's
So
the
this
only
was the fear based on common sense only. So there is no such evidence, and rather it is beneficial. It should be given even injectable also. So thanks to all our learned panelists and thanks to delegates for patiently listening. So now I will hand over to Dr. Anil Sachdev.
Anji, thank you very much, Dr. Jha, for conducting the very lively and interactive panel and with very, very relevant questions. And was a learning for at least for me, it was a learning point. So with that, we conclude the today's meeting and we start the GBM.
Stop sharing the slides, Dr.
Yeah. Stop.
Neeraj, you better stay
stopping it
because
and,
the GBM, you are executive member.